Hello, everyone. Thank you for coming. Welcome to NADO's 38th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments in the chat and questions in the Q&A. We hope you will take advantage of this opportunity to engage with our speakers and attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in our daily drawings. Now, let me turn the stage over to Charles Hawley, NADO's Director of Projects. Charles,
Thank you, Erica, and thank you everyone for joining us for this session, Health Data Programs, Operations, and Success. I am excited to introduce your moderator and one of your organizers, Jenn Toms with Onpoint Health Data, and let me also recognize Monique Cote, who was part of organizing this session as well. So without any further ado, I'll turn the floor over to you, Jenn. Thank you.
Awesome. Thank you, Charles. And thank you to everybody for joining another fun day of some amazing NADO sessions. I am Jenn Toms. I'm the Director of Business Development at Onpoint Health Data. And I am very honored and pleased to welcome you to our presentation this afternoon titled Health Data Programs, Operations, and Successes. As many of you probably know, today's rapidly evolving healthcare landscape, the effective management and utilization of health data is paramount for achieving better health outcomes and also organizational successes. I'm excited for you to join our brilliant presenters on today's sessions as we delve into the intricacies of operating health data programs and explore some of the key strategies that drive their successes. A few quick reminders before we get started with the presentations. Please put any questions you might have for our presenters into the Q&A feature in the Socio platform. We will pause between presentations to try to address topic-specific questions, and we will also have some time at the very end of our 3 presentations to address any final questions. We do have a bit of a lag that some of you may have noticed on the platform. It's about 30-40 seconds between when you're putting in your questions and when we're receiving them. So pop them into that Q&A feature as they come up so we can make sure that we're ready to address them as soon as the presentations end. And with that, I will turn it over to Kevin McAvee from Monique Health, who will be sharing our very first presentation titled Realizing the Promise of All Payer Claims Databases. And with that, it is over to you, Kevin.
Good afternoon. It's nice to see you all. I'm looking forward to interacting with you in the chat and then after this session. My name is Kevin McAvee. It's a pleasure to be here at NADO's annual conference. NADO is an organization I think many of you know is near and dear to my heart, in which I've been a member for many years now. Today, I'm going to talk about realizing the promise of all payer claims databases, specifically state actions to strengthen APCD utility. This is building from a paper I actually put out at the end of last year in December 2022, just after our annual conference. And so it didn't quite make the cut last year, but I'd like to resurface it this year, not just to talk about like some of its federal recommendations, which got the most attention, but actually to revisit some of the state recommendations, which didn't quite always make the headlines, but are really important things that can be done today. So I'm going to share my screen here and move through the slides generally pretty quickly. There's a lot to cover, and I only have about 9 minutes left. So I'm going to be trucking here. So I appreciate you all trucking along with me. And please let me know as we go through whether you have any questions in the comments. I will be in the background trying to lurk and answer as many as I can. And also the slides will be available for review along with the paper, which I will include I will surface in a link in the chat. So really important always for all of these presentations to just know your messenger. For those of you on the line that I haven't met before, my name is Kevin McAvee. I'm a director at Monique Health. Monique is an interdisciplinary consultancy, law, strategy, regulatory, advisory support, and of course, our nationwide data strategy practice. So we work with states payers, providers, and philanthropies to really think through what are our data needs of the future and how can we develop systems to meet those needs. Big healthcare nerd. I think about health data every day, all day. And so if you ever have any questions, whether it's claims and encounter data, clinical data, event notifications, surveillance data, please, I'd love to just chat. The paper that I'm going to reference and again throw into the chat here is the Federal and State Action Plan. It's an enormous document. I wouldn't recommend anyone look at, read it in full, but I think it can be a useful reference guide. Today, I'm going to be focusing on the enhancing state APCD use and usefulness, gaps, and potential solution strategies. And within those solution strategies, again, there are things that states and state partners can do today to address some of their pervasive needs. Very quickly, for those, I think most everyone on this call understands APCDs, but for those who don't, I always like to start off with a little story. The bottom line of which is APCDs are large and complex repositories of healthcare claims and encounter data for individuals receiving health insurance through most public and private sources. Go to the doctor and sometimes the hospital, for some reason, submits a claim to an insurance carrier, assuming a fee-for-service billing arrangement. Those membership and claims data are submitted by state specifications to a state APCD for that payer, as well as for all payers. The state APCD team cleans up, harmonizes, links those data as necessary, de-identifies that data to protect it for analytic use, and then an analyst at the end of the day gets it, looks at it, and tries to figure it out. And how it translates that data into information that can be used by policymakers, can be used by external market decision makers to inform policy, program reforms, business decision making. APCD agencies broadly have a common data collection and curation operating model. Payers submit by a state specification up to state APCDs, but as we'll talk about in a second, not every state has an APCD, which is a barrier in and of itself. About 2/3 of state residents are included in APCDs, biggest gap of which ERISA preempted self-insured data. About 65% of the employer-sponsored insurance market right now. Most of the largest employers are self-insured. Claims and encounter data has a wealth of information, not just about the records of the services that are delivered, but information about the population served, their healthcare needs, from the diagnosis information, the providers that are rendering those services, and the plans by which those individuals have coverage. APCDs, thanks to the APCD Council and its ongoing curation of APCD state statistics, continue to proliferate across the country. The last 4 states, I believe, that have passed legislation for APCDs, not what you might guess, who you might guess, Texas and Georgia, Indiana, Alaska. This is a bipartisan issue in a world with rare bipartisan problems. We are health data provides a foundation on which informed discourse can take place, and states across the country are investing in it. APCDs can be used for a number of use cases. Not all states are using them for these purposes right now, but the best practices are starting to emerge in various states around how APCDs can be used to create and monitor baseline statistics of healthcare insurance coverage, service utilization, costs, identifying inequities, supporting regulatory oversight from network adequacy to mental health parity, identifying health system failures, supporting or better understanding of whole person health needs, and underinvested in use case, providing purchasers, payers, consumers with health service and cost and quality information. But what I would like to talk about today in my remaining 4 minutes here is just highlighting a couple of things that states and state partners can do to address some of the gaps in national APCD data collection, resolving some state APCD data gaps, enhancing state APCD data collection access and analytic alignment, and supporting overall financial and workforce needs. Again, in the paper, we talk about what the federal government can do. What I'd like to focus on is the part of the paper that focuses on what states and state partners can do. There's going to be a lot of text, and this is not a customary presentation for me, but I'm hoping if I send the presentation back home with you, you can review it as kind of an executive summary of the paper. But to start with, ways that states can support national APCD data collection, we can collectively work together to reduce market entry costs by promoting cross-state regional APCD data collection services, filling in the gaps. I know that Colorado, HSRI, other states and vendors are thinking about how they can scale existing solutions for states to states that might not have the necessarily resources to support a new data collection process. We can establish uniform minimum data security and privacy standards for state APCs. This will come back a little bit later on in our presentation. But broadly speaking, when big hesitation states have in establishing an APCD is like, what does this mean for data privacy? If there was a common standard across the country, a common answer for how state APCDs writ large protect data privacy, I think it'd go a long way to filling a lot of those gaps across the country. We can continue to elevate state APCD best practices to motivate adoption and counter local opposition. On resolving state APCD data gaps within the data sets that we get where states have set up an APCD, we can continue to advocate for federal ERISA preempted self-insured data collection solutions. Eric just put out a public letter in response to a congressional RFI that cited the need for a federal APCD for self-insured data, a common collection point with which data the data could be distributed back down to the state APCD agencies. We should continue to advocate for further clarification on 42 CFR Part 2. NATO should continue to develop and working with states to develop non-claims-based payment data standards. Some exciting work I know going on there, even since last year at this time. And then state APCD agencies can continue to serve as state data conveners and solution developers. I can't underline the importance of this role, both for filling internal data gaps as well as to providing broader support in their local environments. And NATO can continue to work to strengthen CDL layout requirements and governance to support harmonization for standards across states, can continue to support cross-state knowledge sharing, to support payer data harmonization. State APCD agencies and their partners can develop minimum state APCD data privacy and security standards and support data privacy and security transparency. The more we can address those questions and comments upfront, even posting our data security practices on our websites, our homepages, the better and the more we get ahead of potential criticism, which is going to be coming our way. Develop a common data application. This is a novel concept being piloted by a couple of states out there. I think it has tremendous promise, both in its like upfront, you can apply for multiple states' data using one application, but also in process and including alignment in data release strategies, where we now see very disparate practices in place across states, sometimes due to regulatory requirements, which cannot be changed, but sometimes it's just because of the way policies and procedures were developed, and that's much easier to harmonize. We can continue to develop detailed state APCD data analytic user guides, foster state APCD analytic learning communities. And then finally, and I know I'm racing through here, but hopefully you'll have plenty of questions that I can both answer in the chat and after the conversation. We should continue leveraging federal Medicaid matching funds, institute protective financial models for our state health data organizations, support budget transparency, emphasize the value that our users derive from the data, particularly around budget season, and think about ways and implement new ways to serve data submitters, including peer state agencies. Again, all in the paper, and I'll throw that link in the chat. There are very specific suggestions on how states can do it, but I wanted to take this time today to lift up those suggestions, let you know that they're in the paper, and I'm happy to discuss any and all of them from a data and strategy side, and also loop you into my colleague, my data privacy lawyer friends to answer any questions on that end, including my colleague, Eric Gold. So it was a pleasure being able to speak to you all for a few minutes today. We're going to have, I think, a couple more minutes towards the end of this presentation for questions, but thank you all, and we'll talk.
Awesome. Thank you, Kevin. All right, we have a few minutes for some questions. So a reminder to our audience to please pop those in the chat. Not seeing any at the moment, so I'm going to ask you a bit of a difficult question here, Kevin. If you can only pick one of each, what do you consider to be the biggest challenge and the biggest opportunity facing APCDs right now?
That's a really good question. I think the biggest challenge facing APCDs right now is continuing to, I'll pick two, continuing to demonstrate their value in state budget environments that are going to continue growing more tight over the course of the next couple of years. It's really, as I think many of you know, I believe in state health data organizations and the value they provide across our healthcare system. Transparency begets questions that help to fix market problems and issues. And transparency, I believe, can also incent competition and reduce cost growth. Actually making the case for why you need X millions of dollars to support your agency is something that requires both quantitative and qualitative data. And for agencies that are often strapped to pull that information together, it's a continual challenge. The other thing I'll put on everyone's radar is, I think nationally, across states, both in the APCD world as well as in the cost growth benchmarking world, we're seeing increased vigilance by industry groups about these transparency efforts, and increased pressure on policymakers to heavily scrutinize transparency efforts and potentially roll back initiatives. I think that stakeholders can get ahead of some of those questions and stalking horse concerns by making sure they have ready answers for how is identifiable data available to analysts? No, and most often, or it's not. Like, the APCD agencies have extensive protections in place to make sure data is de-identified for analytic use, and unless there are legally permissible circumstances otherwise. Getting ahead of questions that could come as criticisms, and also developing strong relationships with legislators to inoculate against some of those misconceptions, I think could also serve APCDs really well. One opportunity I'll put out there, there is a great opportunity for state APCDs to develop stronger, closer relationships with their Medicaid agencies. Medicaid agencies are consistently seeking not only analytic support writ large, particularly in this workforce environment, but also benchmarks, external perspectives on where individuals are moving among coverage lines. Thinking about redetermination right now, state APCDs can provide tremendous value in those conversations. If you haven't spoken to your state Medicaid director recently and their data staff and their policy staff to understand the questions that they're trying to get answers to, I would encourage everyone on this call to make that appointment.
Thanks, Kevin. So other than budgetary restrictions, are there any other common hurdles that you've consistently seen across states as they've struggled to pass APCD legislation?
Yeah, so I actually think state APCD agencies are very cheap. Like they are incredibly valued to represent terrific return on investment. Again, quantifying that return can be a challenge at times. But you look at that state APCD agencies compared to like even health information exchanges, even payer analytic departments, they are quite affordable and can have a significant impact. Other issues that commonly come up that can prove to be hurdles in actually getting an APCD passed, like what types of questions can an APCD help me answer that I cannot get answers to with the data that I have presently available? Having a ready answer to that question that's customized to the audience and knowing their particular interests, whether it's mental health parity or behavioral health, cost drivers, outpatient spending, pharmaceutical spending. I mean, like they're like having those ready answers to the audience is going to be really important. APCDs can provide tremendous flexible insight to the healthcare system, depending upon what the issues of the days are, and they're a tremendous resource. The data privacy and security one is something that's just didn't come up again and again and again. And the more we, again, inoculate ourselves with ready responses, educate our legislators, the more we'll be protected.
Awesome. And I think we have time for one more question. So I'm going to pull one from the Q&A, and that is, what do you think is the biggest opportunity in cross-APCD collaboration?
Oh, really good question. So for cross APCD opportunity, I'll give you two. One, I see that there's tremendous opportunity for cross APCD analytic harmonization. Having worked with multiple APCDs to perform analytic exercises, having common standards for how we're speaking to primary care, for example, outpatient spending, many other analytic exercises, really thinking through how to attach facility claims to patient professional claims, having common processes to do that, I think could be incredibly valuable and allow for benchmarking. And the other thing I'll put out there and give a plug to is a common application. Really thinking about how researchers, other data users could get access to more than one APCD more easily, particularly regionally for multi-state purchasers, I think could be a great value and could actually be a revenue opportunity for many folks.
Great. Awesome. Thank you, Kevin, for your presentation and your thoughtful responses to those questions. We can circle back and ask any additional questions at the end here, but for the sake of time, I'm going to move us along to our next presentation. So our second presentation for today's session will be from Kevin Rogers and Leanne Kandora from the Human Services Research Institute, or HSRI, as many of you know them. Kevin and Leanne will be presenting on standards for APCD use, the common data layout, and beyond. So with that, over to you, Kevin and Leanne.
Good afternoon, and welcome to our presentation on standards for APCD use, the common data layout, and beyond. My name is Leanne Kandora, Vice President and Director of our Population Health Team at Human Services Research Institute, or HSRI. I'm here with my colleague, Kevin Rogers, Director of Technical Services. HSRI is a nonprofit, mission-driven institute that provides services to improve the systems that improve lives. Our population health team has been implementing state APCDs since 2012 and has supported the creation and implementation of data standards ever since. We partner with clients to find ways to enable the creation of innovative integrated data products while reducing overall costs. Our data helps policymakers improve population health and healthcare delivery. During today's session, Kevin and I will provide an overview of the APCD CDL, highlight implementation challenges, and provide options and opportunities for standardization beyond the CDL, even without full implementation. HSRI has compared the data layouts of 3 existing state APCDs to the CDL, and during the session we will describe where alignment already exists and where there are differences, and how these differences can be overcome. The session will end with a discussion on what additional standardization would be needed to fully realize the potential of cross-state analysis of APCD data. State APCDs have evolved and expanded over time, creating a need for cross-state standards to harmonize claims collection efforts. The APCD Council, a program of NATO, has supported APCD data collection efforts with the creation of the APCD CDL, which consists of technical specifications and multiple file layouts. The overall goal of this effort are to improve efficiency, reduce administrative costs, and improve accuracy in claims data collection. The APCD CDL provides a standardized structure for collecting and storing healthcare claims data. This uniformity makes it easier to aggregate and analyze data from different sources, improving data quality and consistency. By using a common data layout, errors and inconsistency in claims data are reduced, leading to improved data accuracy and reliability. This, in turn, enhances the quality of healthcare analytics and research. The use of a common data format promotes interoperability between different healthcare systems and stakeholders. It facilitates data exchange, sharing, and integration, which is crucial for coordinating care, improving patient outcomes, and reducing administrative burdens. While the specific challenges can vary depending on the implementation context, there are a few common reasons why the CDL can be challenging to fully implement for existing state APCDs. For existing states, most have legislation or rules that govern file standards that may not align with the CDL. Data submitters would need to update their systems to remain in compliance with the CDL. Technical infrastructure designs and documentation would be different, and there will be costs associated with updating or redoing internal data systems to intake the data following the CDL, and then there would need to be significant adjustments needed post-intake. While the CDL provides a standardized input layout, there are no corresponding standards on how data are validated, processed, and made available for use after initial ingestion. Each state would still need quality checks against the CDL, newer updated business rules to handle data processing, and updated data structures to store, extract, and analyze these data. Now I'm going to hand it off to my colleague Kevin to highlight the benefits of the CDL, even if a state can't fully adopt.
Thank you. As Leanne said, there are challenges that have held some APCDs back from implementing it, but these don't mean that the CDL doesn't have value. In fact, our experience has been that the CDL has tremendous benefits, even for those that choose against a full implementation. The CDL was developed through an open process with input from many stakeholders. It represents a source of shared experience that states can rely on. It's a living document that is enhanced and revised through a formal process. When a data collection issue comes up in states that we work with, one of the first questions we ask is, how is the CDL handling this? The answer helps inform decisions and encourages cross-state alignment. We view the CDL as a common baseline. Even when states differ from it, understanding how they differ tells us a lot about how non-CDL states differ from each other. It provides a language for us to discuss things like business rules and validations in a state-neutral way. It allows us to develop code once and then easily adapt and deploy it across multiple implementations. The challenges we mentioned aren't insurmountable. States can and do choose to do full implementations of the CDL. In our experience, this is most practical for new APCDs. If you are starting from scratch, adopting the CDL is a great way to realize those three goals Leanne mentioned earlier: improved efficiency, reduced costs, and improved accuracy. But state-level rules and other factors sometimes stand in the way of doing this, or at least limit data collection such that the CDL will be overkill. Also, many of the reduced costs and efficiencies promised by the CDL come over time. Without widespread adoption, it's just another format. Latecomers always benefit from the efforts of early adopters. For many APCDs, a partial implementation is the most practical way to leverage the CDL. Older APCDs and their data submitters have invested a lot of time and effort in their current systems. Changing them can be expensive, and adopting the CDL might not offer sufficient benefits to justify doing so. Instead, these systems can opt to do a partial implementation where the CDL is used to guide and inform changes, but existing processing is preserved. This is particularly useful when planning for new data elements and streams. Knowing that a potential data element is included in the CDL helps make the case that it is worth collecting. This can help get buy-in from stakeholders. It can also help make the case that payers will be able to supply the new data with a reasonable amount of effort if other CDL states are successfully collecting it. But beyond the question of implementation, the CDL helps provide a standard that facilitates communication and collaboration between APCDs. It allows for an implementation-neutral discussion of things like intake validations, data indexing methodology and algorithms, data cleaning and business rules. It also provides a common baseline for discussions of release formats for specific use cases. Different states release similar data in different ways, which can be frustrating for end users. Releasing data in a consistent format helps reduce costs associated with its use. We've been hearing increasing interest from our clients in finding cost-effective ways to enable multi-site data collaboration. The challenges involved with this increase as the number of participants does. This is another place where the CDL can help. Different APCDs have different data owners with different data governance rules, each limiting what we can do with the data. More data owners means more stakeholders at the table. This makes it harder to develop a clear shared vision. And then there's the question of money. Who's going to pay to bring all the data together, and are they willing to support everyone else's use cases? One way to dodge all this is to sidestep federation altogether. Share code, not data. Data governance differences are less important when only aggregated results are shared. Also, buy-in can be easier. Stakeholders can focus on the value being produced, not the steps that get us there. Code sharing is one place where CDL is particularly valuable. Most APCDs have similar structures and field names, but they are different enough to make direct exchange of code difficult. If I want to use code from another APCD, I need to have a good understanding of how that system differs from mine. Are the elements the same? What assumptions about cleaning and validation precede this code? The answers to these questions may require me to make adjustments in order for the code to work in my environment. I must repeat this process for every system I'm bringing code in from. This makes code sharing both time-consuming and risky because I might not have access to all the information I need to make the right decisions. There are a lot of places where things can go subtly wrong. Having the common language of the CDL is valuable because it gives us the option of coding to a common baseline. Contributors can share code in terms of the CDL, making any necessary adjustments to map the semantics. Then anyone else can pick up that code and use it as long as they know how to map from the CDL back to their system. This brings me to a modest proposal that we at HSRI want to put forward, that NATO or a similar entity develop and host a CDL-based code repository for the sharing of code. Many APCDs already engage in robust knowledge sharing. We believe that this would bring this collaboration to the next level. The goal of doing this would be to document a common baseline, not only for data ingestion, but the transformation of these data from its raw state into analytically useful constructs. Of course, not every APCD would choose to do things according to this common baseline, but this knowledge would help the field articulate best practices and reduce the cost of new implementations. We view the CDL as an important first step towards establishing a common APCD ecosystem where everything from data input layouts, processing methodology, reporting enhancements, and release layouts can be easily and freely shared between participants. Of course, achieving that vision will require work beyond what's currently being done. In addition to developing a way to share code, we need participants to think through how what they share would be licensed. Would it be free to use and modify, with or without attribution? Would use of shared elements impose any obligations on the parties? There are many models out there that could be leveraged, but these issues deserve careful consideration before we ask states and other organizations to contribute. Thoughtful licensing is important if transparency and open access are going to be sustainable. In addition to licensing, we'd like to see work groups come together to develop guidance and best practices around things like intake validations, cleaning standards, and common value-add enhancements such as flags, roll-ups, and calculations. New and existing APCDs could benefit from having a robust standard to refer to. Regardless of whether anyone takes us up on a proposal here, HSRI and our partners will continue to make use of and benefit from the standardization the CDL provides. We appreciate this resource and thank the APCD Council and other stakeholders for their investment and efforts in creating this resource.
Awesome. Thank you, Kevin and Leanne. A reminder to put any questions that you may have in the Q&A. I'm going to kick us off with a question, I think, over to you, Kevin. You talked a bit about the differences between CDL and some of the other layouts that APCDs or other data organizations may be collecting data in. Could you elaborate a little bit or provide some examples as to what some of those differences might be?
Sure. The most APCDs, they all originated by copying an existing data layout and enhancing it for their state. But the differences that have crept in are sometimes so subtle that you don't really realize it until you start analyzing the data and trying to figure out why things aren't lining up. So one thing that we've been working with a lot lately is insurance product type. Medical claims data, it has a code on there that says, okay, this is the type of insurance that I have. And the CDL has this as well. If you look across the states, you'll find that they actually have different, that are based on literally different standards. So most of the states that we deal with explicitly source this from what's called the ASC X12 835, and it has a whole list of codes saying what you have. The CDL explicitly calls out the 837 and has a list of codes. On top of that, individual states have taken codes from the eligibility insurance product type and percolated them into their appendix of allowed codes, including the CDL. CDL actually has some of these codes in there. And the problem this can create when we're trying to share data or even code between APCDs is if you don't realize that these codes are different, you can get some very subtle errors. If you're expecting Medicare Part D to be coded with an insurance product type of MD, well, that's not actually an accepted code in all the standards, and not every state APCD is going to do it that way. Now, you can work around that if you're aware of the problem, but how are you going to become aware of that problem if you don't happen to notice it? So having a shared language where we can document, oh, we're different from the CDL in this very subtle way, it'll make people look and help them solve that problem.
Thank you. So as you've thought about, states moving or implementing this, standard to begin with, are there any primary motivations that you've come across organizations have had for implementing the CDL or even partially implementing the CDL, especially as they might contribute to overall goals of data collection or analysis?
Certainly when we've talked with states about whether or not to implement the CDL and how far to implement the CDL, the first thing that comes up is we want to leverage everybody else's knowledge. There's a tremendous amount of wisdom baked into the CDL. And the second thing that comes up is, well, it could be expensive to go all the way. How can we get the benefit of this wisdom without throwing everything else out that we have and without limiting our ability to make changes? CDL, as great as it is, it's essentially a standards process, which can be a little slow to adapt. It's a lot of meetings, and that can be intimidating for some states to take part in. So we have more of our clients saying, we want to pay attention to what the CDL is doing. But to date, we haven't had anybody who's bitten and said, yeah, we're going 100% CDL. Although maybe one day that'll happen.
And in our about last minute that we have here for Q&A before we move on to the next presentation, if there was one piece of advice you could give to an organization that's considering undertaking the implementation of the CDL or something CDL-like, what would that piece of advice be?
Well, from my perspective, the most important thing is to actually make sure you've gone through the layout and you understand what it is you're going to be getting and that it's going to line up with your analytic use cases. That's the most important thing, because every state APCD starts because somebody who's funding it wants to do a particular thing. So it's absolutely critical that you line that up and figure out how you're going to deliver that value with this layout. And if there is a gap, you want to address it up front. And it may be that you need to bring in supplemental data in addition to what's in the CDL to do that, because every state's a little different.
Awesome. Leanne, any final comments?
Just echoing what Kevin just said, I think for a new state coming on board, it is such an incredible starting point, and that it could very well, if state has not had an APCD, it could provide the answers to the questions that they're looking for. And so it's just such a great place to begin.
Awesome. Well, thank you both for your presentation and for your thoughtful answers today. And with that, we'll move on to our final presentation for today's session, which will be from Joanna Duncan and Janice Borgal with Onpoint Health Data, and they will be sharing a presentation on working with sensitive data, methods, compliance, and lessons learned. So over to you, Joanna and Janice.
Good afternoon. Thank you all for joining us. My colleague Janice and I are happy to be here today to talk with you about our experiences and challenges in supporting collection of sensitive data, along with methods for protecting that data needed for program analytics. Next slide. To start our conversation, we want to first create the foundation. As many of you are familiar, the data we work with day to day is protected under several privacy and security frameworks. We can think of HIPAA as the baseline on the left, with progressively higher standards as we move to state laws in the middle and 42 CFR Part 2 on the right. Next slide. As we drill into the specifics, we see the spectrum of privacy-related data starting from confidential, protected financial information, PFI, to protected health through personally identifiable information, PII, to protected health information, PHI, to categories of sensitive information. Sensitive information covers data that, if released, could cause harm to an individual. Next slide, please. And one other category of data to note here, voluntary submissions of ERISA data. And I bring that up not because it is on the sensitive data scale, but is instead a category of data that, like sensitive data, is inconsistently submitted to APCDs. Next slide. And finally, a challenge within APCDs that we all work to address is the inconsistency in the interpretation by submitters of privacy, security, and other submission requirements, leading to an exclusion or withhold of data in these highlighted categories in particular. So how do we identify these areas? Next slide. We have developed benchmarks for typical completeness through surveying submitters and documenting data exclusions. In the table here, what we are highlighting is what we typically see based on payer, commercial, Medicare, and Medicaid. For example, data received from CMS does include SUD records submitted to APCDs, while commercial plans sometimes do and sometimes don't. When they don't, these surveys also drill into the definition of the exclusions, which also vary. The other thing to highlight here is that the two categories that we see having the highest variability of exclusions are SUD and ERISA data. Next slide. The key is to evaluate, benchmark, and document the completeness and limitations of data. What impacts have we seen for data users? Well, we can highlight the range with two examples from other presentations here at NATO. First, work done by the Washington Office of Insurance Commissioner found that due to the large market share of plans that excluded data, there was a need for a special data call to augment the APCD prior to performing their analysis. On the other hand, the Vermont Blueprint for Health were able to confirm the data completeness of similar data that was sufficient to allow analytics to be done directly from the APCD without additional data calls. And with that, I'll hand off to Janice to talk about methods for protecting sensitive data, as well as to discuss strategies for differentiating between the collection and release processes. Off to you, Janice.
Thank you, Joanna. What I would like to walk through next, as Joanna mentioned, are a few methods and considerations to help protect this data when collected and released. First, I'd like to start with comparing the collection of sensitive records to the collection of personally identifiable information, PII. I'd like to start with highlighting the benefits of collecting these direct identifiers. It enables the creation of a strong master patient index that allows researchers to track individuals over time and across payers. It enables linking your APCDs to other data sources, such as clinical registries, birth and death records, and HIEs. Other items like the collection of 9-digit zip codes and street addresses allows researchers to do additional analysis using geocoding methods or are able to use this geographic data to link to other data sources when performing research on health equity. However, collecting this data does not mean that these direct identifiers are released. Instead, we may redact these data elements, such as name and social security number, and replace it with a unique member identifier. We may transform the data, such as date of birth, to the member's age and years following HIPAA guidelines. Other data elements, such as a contract number, if released, may be encrypted. And things like the 9-digit zip codes, like a street address, which can be used to identify a person, as it can provide a street or building level information, may be truncated to 5 digits. So similar to the collection of PII, there are benefits in collecting these sensitive records with the examples listed here: mental health, behavioral health, substance use disorder, genetic testing, gender affirming care, and reproductive care. The benefits include the ability to calculate and report quality metrics, being able to track total cost of care, and to do research on health equity. However, sensitive records are not needed for all research projects, and so they can be handled differently depending on the researcher's needs. They can be redacted, meaning not delivered at all in the data set, or they can be further de-identified or masked. And I'll walk through an example in a moment. But first, let's review how these service records are identified in the data. They're identified using diagnosis codes. This includes the admitting, the principal, and the other 24 diagnosis codes if collected. They include procedure codes, which are your CPT and HCPCS procedure codes, but also your ICD procedure codes, including the principal, and again, all 24 other ICD procedure codes if collected. Provider specialty codes can identify psychiatric hospitals or substance abuse rehabilitation facilities. And don't forget the pharmacy file and looking at your prescriptions. And for those that collected diagnosis in your dental claims, although highly unlikely that there would be a sensitive record identified here, it is worth looking at those claims also. So next, let's walk through an example of how this data can be protected using these data elements. So here is a claim with 3 service lines, all provided by Dr. Patel. It is claim number 1 for the member assigned the unique member ID of 999. The middle record, highlighted in yellow, is our sensitive record, identified by both a sensitive procedure code and a sensitive diagnosis code. So one option is to redact the entire sensitive record. If this record is not needed for analysis, including analysis on total cost, this is a valid option and also follows the minimum necessary requirements. If it's important to include this record, track utilization, or to do analysis on health equity or total cost reporting, there are other methods to protect this record if needed. So for this example, it's required that the provider is not to be identified as a provider of this service. So we have redacted the provider information, and you can see that on the yellow line. However, you can also see that an end user potentially can still back into who the provider is by looking at the other records on the same claim. The same claim number, the same member, in conjunction with other data elements not shown here, like the data service. Because of this, we would recommend also masking other identifiers for this claim. Again, the claim number, the unique member ID, encrypted contract number, anything that ties this claim together for this member and data service, which would then allow Dr. Patel to be identified. You can also choose to redact just the data elements that are designated as a sensitive record. This would still allow for total cost analysis, but may also suggest that this is a sensitive record. In this example, the procedure and diagnosis codes have been redacted, but depending on the type of service, the provider may also need to be redacted. So I hope these examples help to illustrate items to consider and methods of protecting sensitive records when releasing data. And with that, I will hand it back to Joanna.
Thanks, Janice. And as we close, a few items we hope that you will consider as you work with sensitive data within your programs. First, we encourage you to engage your stakeholders to build trust in the handling of sensitive data. Second, developing benchmarks and evaluating the completeness of sensitive data and its impact on reporting and analytics. And third, to develop a robust but flexible masking and redaction method that can evolve with changing analytic needs and priorities. And on that note, we will hand it back to our moderator.
Awesome. Thank you for that presentation, Joanna and Janice. Get a question in place to get us going. So I was wondering, what data access measures would you recommend states put in place as they work toward finding the balance between facilitating research and analysis, but also safeguarding sensitive patient information? And can you discuss a little bit about what role you see data governance playing in managing sensitive data within APCDs?
Yeah, I can take that one to start. Really great question. And I think as you start to think about data access and what analysts are accessing, start with your minimum necessary, excuse me. Start with your minimum necessary data that's required for them to do their analysis, right? As you explore their data use agreements and what analysis they're going to do, always that minimum necessary. I think the second part of that is really thinking about how are the analysts going to access your data? How are you controlling it? How are you auditing it? Is it able to be accessed within an environment that has one set of data that multiple people can access, or are you sending that data out to the researchers to have in their own environment? From our point of view, that best practice is really that one location that's controlled and auditable.
Thank you. All right. So the next question, are there any current trends or emerging challenges that you'd like to highlight, especially in working with sensitive data within APCDs?
Yeah, I can take that one, Jen. So first, just noting that sensitive data, like all healthcare data, is an ever-changing landscape, and what is defined as a sensitive record is also evolving. So for example, reproductive care and gender-affirming care, these are becoming more of a focus area when it comes to protecting patient and provider privacy, when previously HIV might have been more of a focus area. Also, I know APCDs are looking towards collecting more social determinants of health data, other data elements such as a member's sexual orientation or the gender in addition to sex, and those type of things, or additional data collection efforts may also need to be looked at whether they should be classified as sensitive records or not. As far as challenges, I could list a couple. So starting with just looking at the code sets as far as how do you define these sensitive records? So CPT codes, diagnosis codes, provider specialty codes, those list of codes that we went through in the presentation. First, having those list of codes as far as initially defining sensitive records, but also new code sets come out every year. CPT codes get updated, new codes, etc., and keeping up with those code sets so that your definition of sensitive records is maintained, and so that if you're trying to protect those or have rules around protecting that data, they're always up to date. Another challenge I would say is that there's few to no standards around these definitions and codes to define sensitive records. So substance use disorder, you could use Medicare's chronic condition methodology, which is publicly available to be able to define SUD records, but there's no such like public or standard definition for reproductive care, for example. And then one last challenge I'll list is that these definitions, because there isn't a standard, they vary from state to state, payer to payer, researcher to researcher. So not having a standard definition does create a challenge when working with this data.
Thank you. So Charles, for the last 10 minutes or so of our time today, can we open it back up to the larger group for questions? I don't know if we can pull everybody back on stage. There we go. Everyone's popping up. All right, welcome back, everybody. So last few minutes, wanted to, again, to the audience, open it up to any lingering questions you may have for any of our presenters. Kevin, I had one question for you that we didn't get a chance to address during your presentation time. So that was, what successful strategies did you find in collecting ERISA preempted self-insured data?
Yeah, I actually think some of the best organizations that have some of the organizations that have been most effective in collecting ERISA preempted self-insured data are those that steward multi-payer claims databases, voluntary databases. I think that's because they start with the value proposition to TPAs, to employers and purchasers. And I think too often our state APCD agencies, just by the nature of how they're set up, aren't necessarily focused on private sector use cases. And thinking about not only how to engage these communities in our states, but also embed them in the very governance of our organizations is a great way to start to get buy-in for actually collecting that data. I know that other states, and I'll give a shout out to Colorado and Utah, California is making a push to get more ERISA preempted self-insured data in their APCDs. Beyond like public health employee benefit plans, it's an uphill battle. Really kind of embedding the employer use cases by design could be a really helpful tactic.
Awesome. Thank you, Kevin. All right. I had another question for Janice and Joanna to circle back on the sensitive data topic. Are there any potential future developments in the field of working with sensitive data within APCDs that you think researchers and policymakers should be made aware of?
I can start with that. All right. So, we've been talking throughout, some different presentations here around 42 CFR Part 2 legislation. So just looking at that as far as a potential future development, there is proposed legislation to start treating the SUD claims under HIPAA guidelines. Of course, it hasn't been passed yet, but I guess the origination of 42 CFR Part 2 was to provide those additional protections to individuals seeking care for substance use disorder so that this information couldn't be used against them. But an outcome of that was that providers could not share the data to provide good care to their patients. And so out of the CARES Act, the Coronavirus Aid Relief and Economic Securities Act, they're trying to put the release or the sharing of this data more under the HIPAA guidelines so that providers could share this data to provide better care to their patients. And an outcome of that may be that because it's falling under HIPAA guidelines, which still protect patient privacy, but are a little more relaxed within the 42 CFR legislation may allow an opportunity for APCDs to collect that data. Of course, we all know that's all up for interpretation if it does finally move into legislation, but we'll see where it lands as far as APCD submissions.
And Jen, I think I could add a little bit. I think maybe one other option that we could talk about is, I think right now, the social determinants of health data that we get is often at a zip code or a census tract level. With the, as we start to move to being able to get data from fire resources or from other data sources, the opportunity to have that social determinants of health data at the person level, I think starts to expand. And I think as we think about that sensitive data, how might that impact what you're collecting, how you use it, how you release it, is another thing I think everybody should start to think about as we move forward.
Great, thank you. All right, I have one last question for Leanne and Kevin Rogers. So I'm going to expand on this one a little bit. So I was initially just going to ask you about any regulatory or compliance or governance issues that one might encounter implementing the CDL, but I would also like to add on, how do you think a potential code repository might also factor into any governance issues within the state as we look toward more state interoperability?
Well, I can, taking the repository first, just because that's the thing I'm more interested in. I think licensing is the key, and figuring out a good, credible license that allows organizations such as ours to commit code and allow others to freely use it with a clear, explicit statement that they can use it is important. Many times when I have gone to places where they are sharing code, they neglect to clearly state a license. And that means I can't use it, because it still is, it's their copyrighted, they wrote it. Copyright, as soon as you write it, it's there. So unless they are explicitly dedicating it to being shared, it isn't shareable. And too much of the internet is frankly not very clear on this topic. I think if we move forward with a NATO-based repository, having organizations such as mine sign over the code to NATO's keeping and actually dedicate the copyright to them, or at least a copy left, if you will, to them so that they can freely share it out to others, is going to be an important thing to work through. And figuring out issues such as if somebody else modifies the code, do they need to, are they obligated to put those changes back in? What are the mutual obligations that this kind of sharing engenders? We're looking forward to the opportunity to share code.
Yeah, thank you, Kevin. And I think one of the biggest, reasons where we want to be able to share this information more broadly is to have some more depth technical conversations, as we all want to be able to benefit from multiple states, APCDs or other data projects. We're having the ability to share our code and potentially then have use cases that are built off of standard analytic files. Just the conversations that we can have about the use of those data will be much richer, and that the data itself would be able to be potentially more protected because we're having more conversations about the code and how things are being transformed than the data themselves. So we're trying to figure out other ways to really get greater benefit from all of the incredible work done by a number of the individuals on this session, and all of the states in which we're working on health data projects on, to be able to see better value across those projects and states.
Thank you, Leanne. All right, I think we have time for one last question. That's in the chat. If you could pull it up on screen, Charles. That's from Sylvia. You mentioned, this is to Kevin, you mentioned a strategy for collecting self-insured data that would involve those preempted payers in governance. Can you elaborate, since states already have payers involved in their data release committees, but that has had no impact on including the preempted data products.
Sylvia, it's so nice to hear from you and to throw in the hard questions. I'm actually thinking less about the TPAs and the payers and more about the major self-insured employers and purchasers. There are some self-insured employers that are really concerned about getting cross-state data. That's not probably the customer like that we're looking for state APCDs. Maine Health Data Organization has supported their purchasing coalition. I'm thinking about state-based coalitions, really engaging them as part of not necessarily a data release committee, but a data use committee. Really thinking about how a state APCD agency can release benchmarking data, for example, that can help them push back against their TPAs around network design and prices. There's lots of opportunity there. Happy to talk to you offline, but thank you. And thank you, Jen, for having us all. This is a really helpful, productive, fun session.
Amazing. And yes, I know we're at time, so thank you so much to our audience for your thoughtful questions. Thank you to our presenters for the time and effort you put into your fantastic presentations and everything you do on a daily basis to contribute to the ongoing operations and successes of health data programs. And with that, we'll close today's session, and thank you again. Enjoy your afternoon.